Let me turn to the healthcare and health system representatives on our panel and say, what is surprising to you, perhaps, of anything that Burr Woods mentioned? Is it surprising that there is a gap between knowledge and behavior?
No.
Dr. Royer, I'll start with you.
No, I think that tells us that we have our work to do to get the word out about the importance of clinical trials. That's why we at Lancaster General work with the University of Pennsylvania to make sure that people understand what are the latest cancer treatments, how can I access them, and what would be helpful to me, what are the leading edge thoughts, where are we going with research. I think it's important to know that there's still work to be done.
Dr. Hempling, do you find that the level of knowledge has increased over time among your patients, for example?
I think it definitely has increased. There's a great deal more knowledge available to the average citizen by virtue of the internet and a host of other media accesses. Still, I believe that there is a disconnect between the type of material that's available, its veracity and its reproducibility, and what people walk away with when they come away from a website of one kind or another.
Say a little bit more about that. One of the revealing points about this is we asked people, where would you go for information if you yourself were diagnosed with cancer? 41%, the largest percentage, said they would go to the internet. Now, perhaps it's reassuring to say that the second largest category is I would consult my personal physician. That would be 38%. Is that part of what you're referring to here?
Well, in part, yes. I think that that's merely a measure of the awareness of our population of the access of hosts of information from reliable websites, the National Cancer Institute, various university and community-based oncology programs that produce reliable information. On the other hand, one has to be careful. There are no small number of content questionable websites that can lead to disconnects between fact and fancy.
Ms. Kopp, would you agree that there's a gap between factual information and other information that people unfortunately take seriously?
I think so. I mean, when you have patients come in and you start talking to them what they know about their diagnosis and what treatment's coming up, you know that they've gathered their information from a variety of sources. You know, I think the internet allows a lot of freedom of movement. People can go to different areas, so that kind of changes the whole setting of how we impart knowledge. It used to be that the physician gave the patient knowledge, they took it, they regurgitated. People working with the patient then would reinforce the knowledge that the physician gave. Now it's all bets are off. They can kind of go every which way, and I think all of us have begun to use the internet a little bit more and try to guide people if they are going to use it, give them some guides, some websites that probably would give them the best information, and as you said, make sure that it's reproducible and not just, you know, someone else's experience.
Well, let me give each of you a magical medical wand for a moment. If there was one area of information about cancer or cancer awareness that you would like to see in the American public in our region, what would that be? What would make the biggest difference?
Prevention. Prevention is the best medicine. And to prevent cancer, we need to understand our own community, what's going on in our communities. And that's why we take our message out. We know that too many people in Lancaster, for example, die of colon cancer. And that's a cancer death that should be preventable. And we take our message out, get your colonoscopy. That's how you can help yourself prevent cancer.
Burr Woods, what did you find in the survey research regarding people's awareness of prevention behaviors?
Well, I think people understand that there are behaviors they can engage in to prevent cancers, or at least reduce their risk of having the disease. And many people say they're willing to engage in those, but there is a disconnect, and that we find people who are engaged in certain risky behaviors, like smoking, they realize that they can change their behaviors and reduce the risks, but they seem unwilling at the moment to do so. So some way you've got to bridge that gap between what they know and how they behave to get them to behave in a way that will keep them healthy.
Dr. Hempling, have you cracked that particular conundrum, got people from the point of knowledge to behavior change, and what are the techniques that work best in that challenging arena?
Well, if I could do that as easily as you make it sound, I'd be hosting the program rather than sitting on this side of the table. certainly we have evidence, reproducible evidence, that a viable screening program will decrease the incidence of a disease, a lethal disease, and will decrease mortality. The classic example, of course, is cervix cancer and the pap smear. We're beginning to see the same data reproduced from breast cancer after 50 years of mammograms. We're beginning to see the same data from colon cancer. I think an important part of what we need to accomplish as healthcare providers and as administrators is to facilitate access to those tests that have demonstrated that they will have a positive impact upon the incidence and mortality of the disease, and to further explore those possibilities for screening that will take us to a place in a similar situation for those diseases yet to be evaluated.
Were you surprised, were any of you surprised, that fully 35% of men over 40 have never had a prostate screening exam? That seemed a very large and frightening number to me.
No, I wasn't surprised by that at all.
So there's work to be done
Oh,
there.
certainly.
Yes.
Oh, certainly.
On the mammogram question, that 32% of women surveyed had never had a mammogram, and 19% of them had gone 3 years or longer without having had a mammogram.
Well, let's face it, it's not something that you want to line up to have done twice. And to that end, no small amount of negative publicity about having various screening tests when people are particularly feeling well is something that pervades our media and our literature. It becomes rather a punchline. I think it needs to be taken a bit more seriously when we as a group can demonstrate the beneficial effect of screening for cancer in a host of populations.
How can we in the media do a better job of conveying the results of important research? For example, on the breast cancer screening question, recent results and recommendations seem, at least to the general public, to contradict or to be at odds with previous advice. How should we, as non-medical professionals attempting to translate this information, make sure that we're conveying the best information we can?
I think that the screening message is often very complex, and the kind of headlines that people can see in the news don't convey that complexity. And it's not very often that a news flash really changes the long-term outcome of a study. In other words, we don't change our understanding. We don't change medical practice very often by one news item. It really needs to be put into context. And when some new study comes out, it's often the headline that gets attention and diverts from the long-term track record of what's gone before.
So if we in the media not only put new research into context, but I suspect you're also getting at repeating it over time so that there's more than one headline to convey important information.
I think it's true, because what the public hears after you establish mammograms and having a prostate exam, and they hear the news saying it really doesn't make a difference, and insurance companies say they may not pay for the test because of some of the research. I think it's helpful if the media presents a balanced view. And a lot of the news programs we have, we see the report, one study, and then you'll have some of the medical experts that are trying to convey this information. You have to look at the whole broad part of the information and not just one study. But I think that has affected the number of people coming in for, especially mammogram screening. The number of mammograms, screening mammograms, has decreased since the few studies that were released in the past couple of years.
So the distinction between what might make sense for an entire population is different from what might make sense for an individual woman in consultation with her physician. These are challenging times. Let me ask about where the promising developments in cancer research, what are the most promising developments, and in what areas do you anticipate we're going to see the most promising breakthroughs? Dr. Hempling?
It's a remarkably simple and yet exquisitely complex question. I think few of us would argue that the most promising area of research currently ongoing lies in the molecular genetics of the nucleus of the cancer cell. As we've begun to crack the genetic code and distinguish between normal and abnormal function of the genetics of a cancer cell compared to a normal cell. But perhaps more practically, in the day-to-day care of the cancer patient. It's the finding that the translation of the research which comes from that information to the bedside of the cancer patient, and the knowledge that that research must be, in order to achieve optimal outcomes, delivered by an interdisciplinary team of experts. That is the most promising piece of research that I've seen that affects patients on a daily basis.
Dr. Royer, would you agree?
Absolutely, remarkably the same. I think that at this point we know more about the biology of cancer cells down to, as Dr. Empling says, the molecular and genetic level. And for some cancers, that means we actually know what's gone wrong in the cancer cell. And when you have an idea what's causing that cancer cell to behave differently from a normal cell, you have a better chance of fixing it. And just as he said, we need to define the populations who benefit from research, and it means making clinical trials more on the forefront, easier to get into clinical trials so that people can access these changes much more quickly.
You also mentioned a team of experts working together at the bedside. I must say that in our WITF team working on this project, one of the many sources of surprise and revelation to us is how interdisciplinary and how large a team of individuals, of medical professionals, may be working together on a single patient's case. So that brings a lot of talent to bear all on one case, but it also does mean it's complex to manage both from the patient and the family's perspective. Talk a little bit about how each of you helps to coordinate this kind of care so that the patient and the family understands what their options are and how they move forward.
I think it's always been the case with cancer care. I mean, I think sometimes we are a little bit more organized in doing our multidisciplinary care, but for many cancer programs and hospitals, cases are reviewed on a weekly basis, daily basis with a multidisciplinary group, and that would be their medical oncologist, radiation oncologist, and their surgeon. That's ongoing. I think it's developed and it's expanded over time, but those basic tenets have always been there in cancer care. I think what we're trying to let people know that this occurs on an ongoing basis. It's just not the physician and the care team that knows about it, that everyone knows about it.